Hello, everybody, and welcome to Going Deep and Wide on Specialty Contact Lenses, Part 2. Last night we had Part 1, which was very exciting, very interesting. Tonight we have Part 2. So what are we trying? And by the way, my name's Ted Newell. For those of you that don't know me, I'm a business development manager for Eaglet Eye in the United States. And backing me up is Elena Barrios, who is our head of marketing at a little after 2:30 in the morning in the Netherlands. So she's helping manage the chat room and also um, participants as they enter. We will have a Q&A at the end, so you can keep your questions there, or you can put them in the chat as you think of them. If it's something that Elena can answer, she will. Otherwise, we'll save them for Dr. Wolf, who will be with us at the end of the webcast to answer questions. So what are we trying to do at Eaglet Eye? Very briefly, because we don't want to spend a lot of time on our technology. We want to get to cases. But just to let you know what we're trying to do, it's more than just having a piece of hardware. We are trying to streamline the fitting process where we help somebody take a scan and get good images. Then we want to help you analyze that data quickly. And then using that data, we want to work with the algorithms that we've developed with the labs to help create a lens fitting solution for the challenge that you've just faced as you've looked at that data. And then finally, as you come to a lens fitting solution, we want to be able to help you get that solution to the lab so they can make a lens for you. And that's the last of the 4 steps, the lens ordering system. That's what we're trying to do at Eaglet Eye. And tonight, what we're doing is you'll see the images and the technology in action, so to speak, but we won't go through a typical 45-minute virtual demonstration. That's not what you're here for. So the program's called Deep and Wide. Last night we did the deep section. We talked about scleral lenses and we talked about hybrid lenses, looked at a few case studies from uh, Dr. Michaud and also Dr. Morrison. And tonight we're going the other direction because the instrument is a multimodal instrument. Many of you probably know the instrument, the ESP, eye surface profiler, as a scleral lens fitting device, but it's much more than that. We also work in OrthoK, custom soft, corneal GP, and last night you also saw a case with hybrid lenses. So we do everything. And that's our purpose, is to help everyone in specialty lens fitting be more efficient, more productive, and more successful. So tonight we spend the time on OrthoK, custom soft, and corneal GPs. And this is just an indicator of many of the labs that we work with, over 30 labs, over 50 lenses. On the left-hand side, you see the sclerals, which is where we got our start. On the right-hand side, you see the OrthoK, the softs, hybrids, and other custom lenses. And we're adding to this all the time. We do 2 software upgrades a year where we're adding labs and lenses. Now, we're really privileged to have 3 people that have contributed to this as our faculty for this. And this is really born out of the GSLS program that we had in January in Las Vegas, where Dr. Michaud, Dr. Morrison, and Dr. Wolf put together a terrific program. And we've split it in 2 and turned it into a webcast for you. So many of you heard my introduction last night of these 3 remarkable individuals. And tonight I'm going to skip the introduction. I think their fellowship indicators show you a little bit about their commitment to this profession and to their professionalism. And probably many of you have heard them speak at a meeting and or a webinar, or you've read one of their publications. So let's get right to it. Let's get to some case studies on these particular types of lenses, and Dr. Wolf is going to lead us off.
Thank you for having me, Elena and Arnie and Eaglet team. We're going to share a couple cases over here. That's a little different pace from our typical eaglet use. So as everybody knows, the eaglet's kind of unique in its ability to map out the entire surface of the eye, including the sclera. So it is mostly used for scleral lenses. Certainly in my practice as well, we use it mostly for scleral lenses. But we do use it occasionally for corneal lenses and OrthoK as well. It is a full surface, corneal topographer as well. And there are a couple cases in which it can be beneficial. So we're going to go through a couple of those today, which a couple that I think are interesting. This first case that we're presenting is a myopic translimbal OrthoK. So translimbal orthokeratology is I don't know if I'd say new. There are people who have been doing this for a few years, but it just recently became FDA approved by one of our companies, available in the US and in many other parts of the world. So we're going to kind of review that. This is a patient who, 47-year-old white male. This patient was a soft contact lens wearer for a long time. And they were wearing their soft contact lenses continuous wear. Continuous wear meaning that they essentially weren't ever taking them out for several weeks at a time. And they had been doing this for a long time because they were in a soft contact lens that had been approved for that, 25 years ago almost at this point. So, and as we all know in our practices, we don't see this as much as we used to. It used to be obviously a much more common occurrence before we had so robust of daily disposable soft contact lens options. But there are a few patients that are still wearing the lenses like this. And, unfortunately, like many things, it's really not a problem until it's a problem. Okay. And when it becomes a problem, sometimes it can be, sometimes it can be a big problem. Well, this particular patient was one of those. And so they did eventually, after enough years of continuous wear, they did get a corneal ulcer. And so, we of course did treat the corneal ulcer. But looking back as how this happened, well, they weren't really good with their soft lenses, but I don't necessarily blame them in the sense that ultimately the reason that people are non-compliant with their soft contact lens wear, it's not that they're trying to do bad or be bad. It's that they just don't want to ever see blurry. They want to see clearly all the time. And you really cannot blame somebody for wanting to see clearly all the time. So, but it has this risk. They weren't interested in daily disposable soft contact lenses. I don't recall necessarily why, if it was more of a long-term, cost issue, or if it was more of a wastefulness kind of concern. If it was just maybe they kind of felt like they got kind of bit in the rear end a little bit because of the soft contact lenses, so maybe they want to avoid that. They weren't interested in wearing glasses, which is, no shock. I mean, I don't even think that they owned glasses until we had to treat the ulcer. So that was why they had been wearing the contacts continuously. And they weren't interested in surgery. A lot of patients are still a little bit apprehensive about surgical intervention, and I don't blame them for that at all. Well, where does that play in with orthokeratology? Well, they don't want surgery, and they don't want to wear glasses, and they don't want to ever see blurry. There's generally only three main options there. That's going to be, wearing your contacts inappropriately, surgery. And then there's that third option, which is orthokeratology. OrthoK is actually a great option for somebody who wants to see clearly all the time. And, you do see clearly through the lens as well as when you take the lens out. So sometimes these non-compliant soft contact lens patients, they might not be bad candidates for OrthoK. They might be sometimes some of the best candidates for OrthoK. The other benefit with OrthoK in this situation is that we do have higher oxygen transmission in some of these rigid gas permeable materials, especially some of the newer ones. They're extremely high. The amount of time in the lens is also, much reduced compared to what they were doing before with the soft lenses, overuse of the soft contact lenses. This particular patient did also have regular corneas, of course, after the ulcer healed. They were already doing monovision before, which at 47 years old, that's it's going to be somewhat of a factor or concern is achieving vision at both distance and near. So fortunately, they were already used to monovision and enjoyed doing that. So that made it pretty easy to try to mimic that with orthokeratology. And then lastly is going to be, scotopic pupil size. So with adults, this is a particular point of interest. So, when you're doing orthokeratology, most, orthokeratology worldwide is really geared towards adolescence and myopia management, in which the pupil size is not generally a great concern. Sometimes, larger pupil sizes can be beneficial. With adults, that can be a little bit riskier, and so being able to navigate around that is helpful to achieve the greatest nighttime driving vision possible. These are images of the corneal ulcer. You can see that green dot on the left image. And then it's hard to see unless your brightness is maybe turned up, but this is just documenting the resolution. We did, of course, wait until the cornea was very stable and very healthy. This is some background information about this patient's eyes. So they're a moderate myope, very typical myopia, roughly -3 myopia, a very typical presbyopic ad. Left eye was dominant. I do recommend a sensory method approach there. That's basically taking a plus powered lens to blur each eye and determine which eye is dominant from that method. All right, so they could do either one, right? They could do a corneal lens, which is your traditional OrthoK, is what almost all the orthokeratology manufacturers create. That's a lens that's slightly smaller than the size of the cornea, and then also a translimbal lens. The reason that we went with the translimbal lens was ultimately the bigger the lens, then the bigger I can make the optic zone. Okay, and we'll have a slide coming up that kind of describes that a little bit. But you're playing around with surface area. And so the surface area of the lens, if you can extend that all the way as far as you possibly can to the edge of the cornea or near it, well, then you can extend the optic zone out a little bit wider too. So that can be advantageous, particularly for adults. The other reason that I kind of prefer a translimbal lens for this particular case is that when you have a greater amount of surface area of the plastic lining up to the surface area of the cornea and compared to a smaller corneal lens, you do tend to get better stability. You get a little bit less movement, which also means less, lens awareness, corneal sensation awareness. You tend to get better centration as well. So that was a lot of it as well. The other reason is that this patient, we really kind of wanted to get a very high success rate early on. They had been used to wearing their lenses, for very long extended time. They probably were particularly comfortable because they probably had some corneal nerve damage as well. But ultimately, comfort was definitely never a problem for them before, right? Whether they just, were very, uh, you know, um, easy going as far as, some eyes are less sensitive than others, or they'd had maybe a little bit of some again, corneal nerve sensitivity issues because of the way they were wearing the lenses. The one thing that we know was never a problem for them before was comfort. And with orthokeratology, the comfort is generally good, but it's not quite as good as a soft lens, of course, right? So we want to try to mimic that as best as we possibly can. The larger size lenses, they do tend to do that a little bit better. They do tend to be initially a little bit more comfortable, partly because of the centration and the stability. So the reason we use the eaglet for this particular case is because we did choose to use a larger size lens. And in order to use a larger size lens, you need to capture all of the corneal data. And in fact, I would say beyond the cornea, you want to get maybe, even beyond the limbus. Okay. This is the examples of his maps. Excuse me, the right eye is on the left side of your screen. The left eye is on the right side of the screen. This is in what's called quad view. So you're going to have an infrared image in the top left corner. That's basically what the operator sees. And then within that infrared image, you're also going to have some quality score metrics, okay, where you'll see focus and centration and coverage. You obviously want those as high as possible, and then the higher quality scores will be green. The more questionable scores will be yellow, and very, very poor scans may indicate red. Of note, you'll notice that the coverage on both eyes is yellow. Well, if you're not familiar with eaglet, and certainly if you are, you know how important the tear film is. So the eaglet is taking a map of the surface of the eye by projection method. And so it's projecting a grid onto the tear film. If you have poor quality tear film, you're going to get a poor quality grid projection, and that's going to give you false data, or what I would call artifact. So it's really important to have a high quality, smooth tear film. And with scleral lenses, sometimes you need to get a much wider view because you're using a much larger lens, in which case you may be willing to accept a little bit more tear breakup time for the trade-off of the greater diameter of data. But for corneal lenses and OrthoK lenses, you really want to get the best quality tear film possible, and you don't need all that data of the sclera. So you really just want to focus on getting the eyelids just wide enough for what the purposes you're trying to achieve. If you're trying to achieve a corneal lens, you just need the lids beyond the cornea. If you're trying to achieve an intralimbal, sometimes referred to as corneo-scleral type of diameter, well, you just need it a little bit beyond that. You don't need a wide view right there. On the top right, that's your tangent angles map. The tangent angles map is essentially a visual representation of your quality data and your quality tear film. You want to see nice smooth curves, nice smooth color changes. Okay, the colors are less important, to be honest, in this particular map from a quantitative data standpoint, and it's really more of a qualitative measurement. But you can see on these particular images, these are really nice smooth maps. The bottom left is going to be your traditional corneal topography elevation map. You can see this person has, a very mild amount of with the rule of astigmatism, but really very negligible in quantity. And again, you can see that the centration looks good. This is a normal, regular cornea. There's no signs of any ectasia. Then when we go to the bottom right, that's going to be your more traditional bisphere map. Your bisphere map is basically, you have a best fit line, a best fit sphere line for the cornea, and you have a best fit sphere line for the sclera. So two different best fit curves, or two different best fit spherical lines equals your bisphere. All right, and so you'll see we are getting all the way out to the cornea and the limbus and a little bit beyond, okay? Of note, these are also interesting because you can see that although the cornea is with the rule, with the cooler colors at 12 o'clock and 6 o'clock, slightly warmer colors at 9 o'clock and 3 o'clock, when you go to look at the sclera, you can see it's actually opposite. You have cooler colors more at 3 and 9, with slightly warmer colors of the green at more, 12 and 6, or in this situation, more like 1 and 5. So that's just a nice little aside that, what the cornea shape looks like and what the scleral shape look like, they are not always in line with each other. These are pictures of the designed translimbal OrthoK lens, okay? The central part is going to look like any traditional OrthoK lens you've seen before, okay? It's going to have your green right here where you have your reservoir. It's going to be darker in the middle where you're trying to flatten or compress that central corneal tissue. And then it's going to be darker a little bit in that peripheral cornea because that's where it's aligning to the surface of the eye. Now, where it gets different, though, is you can see the size of the cornea and the size of the lens. The lens is clearly larger than the cornea. That is a translimbal orthokeratology design, or is sometimes referred to as a corneo-scleral OrthoK design. Now, you'll also notice that you still have tear exchange at the edge, what we call edge lift. And the edge lift, or where the green starts to appear, is before the edge of the cornea. So the lens, although is bigger than the cornea, it does depart from the cornea before the end of the cornea. So if there is concern about limbal health or limbal compression, you do not have to worry about that just because you're in a larger translimbal design. It's not actually bearing down at this part. It is still lifting up for you to get healthy tear exchange. The other thing that you'll notice in the top photos, these are your infrared images. I'm a big believer in infrared photography. I use it all the time for any number of different situations in my office, but it's particularly, I think, good in orthokeratology and probably underutilized in orthokeratology. You can see your central back optic zone diameters, okay, by this kind of ring that you see in the background. You can assess your centration, again, with translimbal design orthokeratology, get excellent centration. You can also see what the pupil size is going to look like in a scotopic environment. Okay, you really have no other way of doing that in your exam room when you're looking at the lens, other topography instruments. You really never get to see how the lens and the eye are going to interact, or how your treatment zone and that pupil, nighttime pupil, are truly going to interact. So this is a great in-office, in situ environment here. What you're looking at on the screen right now is an infrared video of the fit of the lens. I also think this is underutilized in examining or evaluating the fit of really any contact lens. And essentially, when you shine a bright light at the eye, not only is it going to make it more sensitive for the patient, but you may get the eyelid in the way a little bit. Again, you're not assessing the pupil accurately compared to a nighttime environment. It's just overall more comfortable. You can assess anything from centration, movement of the lens, everything without turning the light on. So it's much preferred, in my opinion. What you want to see on a translimbal orthokeratology fit is you want it to essentially look like a soft contact lens. You want the lens to move subtly with eye movement or with blink. If they look up and they blink their eyes, it's very much just like a soft contact lens, maybe half a millimeter to a millimeter of movement. But you'll get less movement than what you will typically see with many of the corneal OrthoK designs. What you're seeing now is a fluorescein video of that same fit on the same eye. And again, you can see that the centration is excellent without the lid propping the lens in position. Again, you can see that there is some movement there. You can assess fluorescein in your mid-periphery kind of reservoir, as well as your edge lift. You can also assess if it looks like there's any bearing in that central cornea. Both are important to examine. This is your post-treatment map. So with the eaglet, because the eaglet is a corneal topographer, just like it is a scleral topographer, these are just examples of corneal topography maps. So what you'll see on the top is going to be axial maps, and then the bottom is going to be your tangential maps. Your axial maps are going to be relative to one entry point of light. Basically, axial stands for your visual axis. So it's they're going to look a little bit different. All the curvatures are essentially relative to that one visual axis, kind of perpendicular angle into the eye. Tangential would be like if you had, hundreds of these little kind of tangential lines in contact with the cornea, and you're looking at the shape of the cornea more relative to all these many different perpendicular points of contact against the cornea. So those maps will look a little bit different. You can generally think of the axial maps more relative to vision performance, power change, and maybe the tangential maps more accurate as far as what's truly happening to the shape of the cornea. On the left of the axial, that's going to be just your post-treatment map, and on the right is essentially your pre-treatment map. You can put them side by side if you like to look at them from a side-by-side view, and you can also utilize difference or subtraction maps. You'll see on the right image, or the right half of the screen, which is actually the left eye, you'll also see a little kind of blue spot right there. That little blue spot is what we refer to as a false central island. So the eaglet's unique in this way. Almost every instrument, if not every instrument, corneal topography, tomography, etc., will use what's called interpolation. Interpolation is basically taking two data points and blending the data together for any unknown data points. So if you have two known data points around each other, or multiple known data points around each other, and then you had an area of unknown or unpredictable, unreliable data points, the computer will basically smooth it over, and that's interpolation. The eaglet doesn't do that. So the benefit of that is if you do have a focalized area that's maybe not getting compressed as well, or maybe you had some punctate staining or anything that could actually be real, the computer and the software, it won't hide it. Okay. Now this good and bad. The good is it's going to give you a more accurate, more precise representation of what you're actually seeing. The bad is it does require you to then be very careful about your tear film. You could be looking at an artifact, so then you would go back and you would review the quality of your maps. Okay, and these are excellent quality maps. So that's just an area that's just not quite getting compressed all the way and not a big deal. In fact, if you look on the right, you'll see your color scale. Okay, your color scale is the same as any other corneal topography device, where you have warmer colors, which are going to indicate more of a curvature, a steeper curvature, and you have cooler colors, which indicate a flatter curvature. Again, these particular maps are curvature maps and not elevation maps. And then in the middle, you're going to get kind of neutral, okay, which is basically like green. So if there's been, change, we still expect to get this cooler color. So we have this kind of blue everywhere and then a lighter shade of blue. So even though it's not as dark as the blue around it, it is still blue, which means we are still getting compression. We are still getting flattening. So that's also part of why this particular patient, as you'll see, did not notice any issues in their vision from this. Not concerned about that. What you're looking at now is going to be the difference maps. And so I mentioned that you can have your maps side by side, or you can have them in a subtraction pattern. So this also will bring up a quad view appearance to your maps. The top left is going to be your baseline. So this is not your post-treatment bisphere map. This is your baseline bisphere map. Okay, we've seen this image before. And this is an elevation map, not a curvature map. When we go over to the top right, that's where you're going to see your curvature map, and again, the axial curvature. And again, you'll always see a larger area in the axial maps because it's just, again, taking data relative to that one central entry point that is straight ahead visual axis line of sight. Okay, so you'll get a larger pattern there. And then when you look down to the bottom right in these maps, you're going to see your tangential maps, okay, which is again going to be more about the shape of the cornea, more accurate from that standpoint. Going back to our color scales, you'll see that the numbers are much lower, and that's because, again, this is a difference. So a 0, which is basically a green, which is the most neutral color in this scale, that's going to say that essentially there's no change at that location from the eye before and the eye after treatment. And then we have warmer colors. The warmer colors are going to indicate more change in a higher direction or steeper direction. And then your cooler colors are going to indicate more in a flatter direction. So you can look at each of these and basically determine what your treatment zone size is by, well, where the green is. And you can say, okay, I see some green over here, maybe about 1.5 millimeters, maybe 1.75 or so, to the about 3 o'clock position. And then I can come over on the same eye and I say, okay, well, where's my green begin? I don't know, maybe it's a little bit further, maybe about 3-ish or something. And then you add that together and you would say, okay, well, I probably have about, 4 to 5 millimeters there. And your power maps up at the top and your axial maps, it's the same thing. Where's my green start? Well, my green's a little bit further out over here. Okay, maybe it's a good 3 to 3.5 millimeters. And then on the other side, it's probably about 3.5 millimeters. So that's probably about a 7 millimeter, okay, range as far as where my change is happening. And if I look at what this patient was, and they were like a -3, okay, I think they were around a -3. Then I look at my scale and I say, okay, where does about 3 happen, which is more of a kind of a purple. Well, where does that kind of purple indicate? Okay, now I'm probably at about, I don't know, 2-ish out to maybe 1.5. So I'm getting about a good maybe 3.5 millimeters, 4 millimeters perhaps of my absolute best distance vision, and it'll fade off a little bit from there. With this particular patient, their pupil size, that's fine. That's gonna be great, especially they're almost always in daytime lighting or well lit rooms. You can get the same information by going down to the bottom left, and that's your power profile. Your power profile is also a from your difference map here in the power. So again, 0 would be there's no change. And then as the line scoop down, that means that there's more change. That's how much myopia, how much power change that you're actually changing. Okay. The green and the red lines are just indicative of your primary meridians on the cornea. And both are, as you can see, coming down to around 3 to 3.25, which is what the power was of this particular patient. And then you can see the scale on the far left there. And then likewise, you can determine the width of your treatment according to the scale on the bottom or the x-axis. So y-axis would be your power change. X-axis would be position on the cornea. On this particular map, the other thing worth noting is from the eye dominance, okay? We did make the treatment zone bigger on dominant eye, a little bit smaller on the non-dominant eye. Okay, when we look over here at the results, ultimately unaided before was not very good, very typical of a -3. And then when we look at the post results, again, being in monovision, kind of a mild, immediate monovision, you can see that the right eye is somewhere around maybe a -5, or I'm sorry, about a -0.5 diopters, and maybe with a little regression up to maybe about -1 diopters throughout the day. So that's going to be great for near vision, computer vision for a 47-year-old. And then on the left eye, same thing, about a +50 up to, with some regression, probably gets about plano or so. So again, this patient had really great results, 2015 vision, very happy with both distance and near vision.
So you'll see my theme for today appears to be post-refractive, and it really is with this next case. I am going to switch gears now and move into corneal GPs. And we will go through a couple of very quick examples, not a lot of detail on these cases, because the whole point of sharing these is to talk just a little bit about how the process of fitting corneal GPs can be very analogous to OrthoK and sclerals, diagnostic versus empirical fitting. So, we know that we can get to the finish line with a variety of different ways. In fact, there are, again, many different ways that we can fit contacts, and more historically, we'll say, is not the wrong way. Fitting with a diagnostic set is absolutely, with an expert fitter, can be done in a very short amount of time with a high level of precision. Now, on the other side of it, that I'd like to just share a few cases, we really do have the ability today, again, very similar to OrthoK and sclerals, to design corneal GP lenses based on digital data. What that allows us to do is free up our intellect and our time to spend on really getting to know patients. So, what are their visual goals? What are the things that they've tried that they have not been happy with? What are their dreams for the future for their vision and their contact lenses? And then also having more chair time in the short time that we have to spend with patients to think about complication management and prevention, things like that. So I have two cases to share, cases that we utilize digital design using ESP to get to a first lens fit. First one is a 52-year-old male. He's also post-Lasik. His history is that he had refractive surgery with a higher level of prescription at one point, very oblate shape, unable to wear soft lenses just because sometimes after patients have refractive surgery, well, again, back to our story, number one, they don't want to wear glasses or contacts anyways. Glasses are out. This patient, not able to wear soft lenses, that did provide fairly decent distance vision about 10 years ago. And that's largely because after we have a tabletop shape after refractive surgery, a lens that fits more of like a standard eye with kind of a round shape flexes and doesn't really sit very well on the eye. And so his only option really was to go into a hard lens. And he was in corneal lenses at one point, and failed out of them due to fit discomfort, poor vision, and came back and found another option with us. So he presented thinking that he would try something new. He had done a lot of research and was aware about some of the mapping technology that we had at our office, and kind of came to me and asked if he could be measured with the technology so that we could try to design something new that he hadn't tried before. Now, a take home of this section is that profilometry is not only kind of, we think about it as comprehensive ocular shape, and naturally we kind of picture those images that have a huge, big eye map that is very, very appropriate when fitting scleral lenses, but something that we sometimes forget, or we're sort of emerging into an era of kind of exploring more of how can we best fit corneal GPs and OrthoK using profilometry, is that the unit is very successful and accurate in measuring the corneal shape as well as the scleral shape. So what you see is a picture of a cornea, and you can see that central flattening in this patient's case where he had refractive surgery. And I wanted to share, again, same process, utilizing an algorithm to design empirically. Here's a case that was successful on the first fit, comfortable with his lens, very little time spent on my end so that I could really kind of dig in a little bit more to how can we now apply the multifocal optic that you want. Make sure that we're watching for complications and things like that. So I wanted to share just kind of some digital images here as well, or some anterior segment images. This was a first lens fit based off of empirical design on a trickier eye to fit. He tends to get central adhesion with a lot of kind of fits. In fact, I had tried diagnostic fitting him at one point just before we did the mapping, just to kind of see, because I needed his acuity potential, and found that a lot of even a very, very flat corneal GP fit almost like an OrthoK lens on him. And so, using tech rather than flipping around with different lenses, which can be really useful to show a patient what a lens feels like on the eye. But on the flip side, it can take a lot of time. And so empirical design in this case was successful to kind of get him going with something that was very appropriate for fit and allow us to focus more on how do we now apply the multifocal to this design and customize that to make sure that he's really, really happy in the end.
I want to present another case, and this case is going to be different in a number of ways. Probably the most remarkable difference is going to be, this is hyperopic OrthoK versus the previous case was our more traditional myopic OrthoK. This is also another adult OrthoK case. So this is a 63-year-old white female. They're a moderate hyperope, roughly around a +3, plus 250 to +3 in that kind of ballpark. They're a more mature presbyope with a full 250 add, and then same thing with fogging method or sensory method dominance. We find that they're left eye dominant. This patient had been in hyperopic OrthoK before and another design, and really we're just struggling with some decentered treatment. So we decided, I think that we can do better. Why don't we try again? But in order to try again, we need to kind of stop our current OrthoK, let the corneas revert to their normal baseline shape, and that's what's called a washout. So we did a washout for 2 months. They had some dry eye. I think that, I do not recall, but I believe we're treating their dry eye as well. Corneal shape was normal. All the other features of the cornea were very normal. Didn't anticipate having any particular issues here. The goal is to do, again, hyperopic OrthoK, which ultimately creates a near center multifocal effect, kind of like you would see in your soft multifocal contact lenses or even multifocal rigid scleral lenses too. But as with myopic OrthoK, flattening the middle of the cornea and then steepening around it, that would create essentially a distant-centered multifocal optics. Hyperopic OrthoK would be reverse. So you're actually building up tissue in the middle, flattening some of that mid-periphery, and that would create essentially a near-centered multifocal optic. So that's what we're trying to achieve so that we really don't ever need glasses. What we found when we started the process was we had a harder time getting good quality maps than we initially anticipated with traditional corneal topography. This is an example of the corneal topography that we were getting. The eyelids, what I did not anticipate was essentially just how tight and small, basically that palpebral fissure was. Okay, well, although these would be certainly maybe an adequate map for the right eye, the left eye really just wasn't very good. Didn't instill a lot of confidence in this map. If this had been a myopic case, which is a little bit more straightforward, maybe a little more predictable, and certainly, we all have a lot more experience and comfort with myopic OrthoK, maybe this would have been fine. Maybe this could have worked. With a hyperopic OrthoK, it's already more complex. It's already more complicated. And our goal is a little bit more ambitious as well for what we're trying to achieve for this patient. It just, ultimately just did not feel comfortable designing lenses off of what turned out to be the best quality map I could get for this left eye. Fortunately, I had the eaglet. The eaglet is a corneal and scleral topographer both. And with the eaglet, there are some advantages. One advantage is going to be the working distance between the instrument itself and the eyeball plane. So you're going to add several inches of and several centimeters of space there. That allows for me or any other clinician or staff member to be able to kind of get in there and manually get the eyelids open. You really can't do that very well with many of the corneal topographers, particularly the more preferred corneal topographers with OrthoK, because just the space is too close together. It makes it really difficult. As you can see in the infrared images, this is just like there's a Q-tip. I'm using a couple cotton tip applicators to basically hold and pry the eyelid as wide as I can. And if you're used to seeing a lot of these eaglet maps, you can really appreciate that this is a very small eye with very tight eyelids. I'm cranking that about as wide as I possibly can, and we're not getting a whole lot further out than the cornea. But the point is, and as mentioned in the previous case, I don't need a lot of data out there. I really just need corneal data out all the way to the limbus, and we clearly get that, and that's a nice quality map there. As you look at the metrics just show, again, a normal cornea, normal Ks, normal eccentricity, normal size to the cornea. There's really nothing irregular to note. On the left, that's just kind of checking, well, how much, elevation change happens at about that 8 mm range, which is, it's just more or less, where your contact lens is kind of aligning to the eye. And it's just a nice 8 mm, 9 mm. Those are really nice chords to look at when you're looking at corneal data. And it just shows this very, very minimal corneal elevation changes there. This is the map for the left eye. Again, you can see I have high reliable, high quality maps of the cornea. Maybe not as much beyond the cornea at maybe 1 o'clock, but I don't care about that because I'm not fitting a contact lens out there. So I really am not concerned with the quality of that data. Just within the cornea. The metrics also show a normal curvature, eccentricity, elevations minimal. Okay. These are very nice corneas, should be very predictable. The lens of choice was from a software design, what we call a CAD/CAM, computer-aided design, computer-aided manufacturing type of software. There's a number of these out here. This particular one is a design called Wave. Wave has been around for a number of years, and you can do some very custom, very sophisticated designs here that make corneal lenses, orthokeratology lenses, and scleral lenses. This is just an example of what that Wave software looks like for the right eye. You have the lens at the top, and then at the bottom, you're going to see your kind of tear film, tear layer profile map. If you're used to seeing this in designing OrthoK lenses, you'll note that this is very much the opposite, where the curves would dip down in myopic OrthoK. They're now going up, and everything is basically backwards. It looks very very atypical to what you're used to seeing. But this is the right eye in both horizontal and vertical meridians. This is the design software for the left eye, again, both horizontal and vertical meridians. I won't get into all the details of the Wave software because it's beyond the scope of this presentation, but because it is a near-centered multifocal effect that we're going for, you can adjust what would be basically your optic zones, your near optic zone, to your intermediate and your distance optic zones. You get to adjust all that with this design. So I did make the dominant eye, that left eye, I made that near optic zone, near portion, a little tighter, closer together than I did on the non-dominant eye just a moment ago. You can also see a nice visual representation in the top left of these images of essentially what the lens would potentially look like on the eye with a fluorescein pattern. That turns out to be very, very accurate in most cases. This is our eaglet difference maps. We've already discussed kind of what you're looking at in these images. So this is going to be your baseline map for the right eye, the baseline elevation maps for the right eye. When we look at your axial maps, again, you're going to notice that, generally these kind of central colorful patterns will be bigger on the axial maps, a little bit smaller in the tangential shape maps. One thing that's very different than the previous one is going to be your color scales. Okay, you'll see that things will be warmer in color centrally versus cooler in color in the periphery. Okay, you'll also notice in your power profile map that these lines now work upwards as opposed to your traditional myopic maps as well. When you're looking at these particular pair of eyes, you're going to see that the right eye has a larger kind of warm spot in the middle, larger treatment zone, essentially hyperopic treatment zone in the middle. And on the left eye, you see it to be much smaller. As I mentioned, going back to the wave designs, we did do that intentionally, bringing those points of curvature closer together. You can see that also reflected in the power profile map. The power profile map from side to side is more compact than it is on the right eye, which is wider. These are what the results are. So you can see in the picture, and again, you may have to turn your brightness up to be able to see it really well, but you're going to have kind of a green spot in the middle. That's basically an area that you're pushing tissue into. So instead of compressing and flattening that central area, we're actually trying to create a reservoir. So there's a little bit of a space here that the fluorescein is working its way into, because that's that reservoir that we're going to push those cells into to essentially mound it up like a little hill. And then you have the black around it, which is kind of where you're getting some applanation. And then around that, you're going to have some green where you're kind of pushing some cells out of the way, right? And then also that allows for some tear exchange, which creates a healthy, physiologically sound fit. This patient, one and done, meaning we didn't require any revisions. They had 20/20 vision at both distance and near. Very happy, very good stability. Really, again, only achievable, in my opinion, in this case, because we were able to get all of the corneal data that we needed, and it really took all the guessing out of it. So this is a diagram that essentially just compares, again, myopic and hyperopic OrthoK. If you look on the left side of your screen, this is a traditional myopic OrthoK pattern, and the right side is going to be a hyperopic OrthoK pattern. Okay, so when you look at the colors in your axial difference maps, and then you look at your scale, again, neutral would be green, anything cooler would be essentially a flatter curvature, or which would indicate basically compression of that central tissue, and anything warmer would be steeper. Okay, so that's what we're trying to achieve in myopic OrthoK, get a cooler pattern, a flatter central cornea. All right, and you'll see that on both the axial and tangential cooler colors. Now, when you switch over to the hyperopic OrthoK, you'll notice that all those colors are now reversed. Going from green, we're going warmer and warmer to yellows and oranges and reds, because we're trying to push tissue into that area to create a steeper central curvature, or more steeper, higher central elevation as well. And so you'll see that these colors are in fact reversed from each other, and same with the power profile. You'll see that the power dips down for myopia and pushes up for hyperopia. So ultimately, you're looking for a central optic zone to be nice and well centered, as big or small as you intend to design or as you need for good optics, but everything will be reversed from each other. This last slide that I'm going to share is basically just a comparison slide between our more traditional corneal OrthoK and our slightly larger translimbal OrthoK. One is not necessarily better than the other. It's not necessarily the point I'm making, but I think there are advantages to the translimbal OrthoK that we don't necessarily have in corneal OrthoK. So what I'd like to do is just kind of think about it on the same eye. Let's say you have a very average eye. It's about a 12 millimeter cornea. Okay, and you want essentially about a 6 millimeter optic zone, which is, again, it's a very, very standard kind of starting point in many of our OrthoK cases. On a corneal design, if we take that 12 millimeter size of the cornea, we're going to want the cornea, the lens to be slightly smaller than that, not much smaller, but a little bit. So people may have different rules about how they get there, but it's going to roughly be about 11 millimeters. It's probably about the size of your corneal lens, or the orthokeratology lens. If the whole thing is 11 millimeters, you have to remember you're going to build in some space at the edge for tear exchange. That's called the edge lift. And that's roughly about half a diopter. But you have half a diopter, which would be the far green in this diagram, on either side. So that really equals, 1 diopter. So that means the amount of space the lens is actually in contact with the eye is actually only about 10 millimeters. I'm sorry, I misspoke a minute ago with half a diopter. I mean half a millimeter, right? So that's gonna be 1 millimeter. That leaves you with about 10 millimeters of actual contact, surface area contact against the cornea. But now you have to remove, about 6 millimeters of that, because that was what your back optic zone diameter was. So now we're down to 4 millimeters, but then the end of the back optic zone now has to also go back to the cornea. Okay, it's lifted off the cornea in that location, and it has to return to the cornea. So that's what we call the return zone. And so that return zone, you're going to have on either side of your treatment zone, or that back optic zone diameter. And the total between your back optic zone diameter and that return zone is typically referred to just as your treatment zone. That doesn't leave you a lot of space when you do all the math. That means that we basically have, roughly, 2 to 3 millimeters of our sum or our difference. But then you split that on either side of the eye, and now you only have 1 to 1.5 millimeters of actual surface area of the plastic touching the cornea. So when you think about, you started with a 12 millimeter eye. Of that 12 millimeter eye, you only have about 1 millimeter of space for the lens to really appropriately kind of support itself in each part of the cornea there. Now, when we go to the translimbal design and we just work the math backwards, basically we want a lens that's slightly bigger. So we aim maybe roughly a millimeter less than the cornea, maybe just, maybe roughly a millimeter larger than cornea. So we'll go beyond that. But you do still want the cornea to get adequate tear exchange. So you do still want the edge of the lens to depart from the cornea before that limbus. So I usually describe that more like an airplane on a runway. If you have a longer runway versus a shorter runway, it seems beneficial. You may not need a longer runway, but you certainly don't want a short runway. And if you do have a longer runway, you can use really as much as you want of it, as long as you take off before the runway ends. Okay, you might as well. And it's the same thing with these lenses. So you're going to basically want that lens to depart from the cornea just shy of that limbus. So that's going to basically give us a math of about 11.5 millimeters of space where the surface of the plastic of the lens is touching the cornea. And that's much bigger than that previous 10 millimeters. Now, of that 11 millimeters or 11.5 millimeters, then we're going to work the math the same. Basically, you have the same optic zone. You have the same, reverse curvature kind of width, or return zone width. And that's going to essentially give you your overall treatment zone. And that's the same between the two designs. But when you factor all that in, now you've got about, on either side, about 1.75 to about 2.25 millimeters of landing zone. So all you did was, instead of going a little bit smaller in the cornea, you went just a little bit bigger than the cornea, and you basically doubled or nearly doubled the amount of surface area that you now have to control the centration, the movement, and really to a large extent the comfort of the lens as well. So I do think that the translimbal OrthoK design is really, I don't know if I'd say it's the future and we're going to abandon corneal OrthoK design. I don't think that at all. But I do think that we will see this grow. We're going to see more in our markets with translimbal designs, or sometimes referred to as corneo-scleral OrthoK designs. I think there's a lot of advantage to them in many cases. Particularly when you want to go bigger with your optic zones and your treatment zones. I think that you can always go smaller. There's no trick or really difficulty with making your treatment zone smaller. Either lens can go really small, but not both lenses can always go really big in that regard. So this is just a nice little summary between the two. If you are planning to do a more translimbal OrthoK design, I really recommend something like the Eaglet Eye Surface Profiler, because you need reliable data of the full cornea if you're going to fit the lens to the full cornea and again, potentially, beyond the cornea. There are some corneal topography devices that can do that, that can get you really far out, but it may be difficult in a single shot, or you may have to stitch multiple images together to get there, and there's some potential risk of data blending and precision kind of reliability when you do something like that. And frankly, most corneal topographers, that's just not an option. Most corneal topographers, you'll be lucky to get 9 or 10 millimeters of data, much less 13, 14 millimeters of data. So where something like the Eaglet comes in is that it will just map out the entire surface of what you're projecting the instrument onto. I'd like to again thank Eaglet Eye for inviting me to participate, and then they can share any of my contact information if there's any further questions about any of these topics.
Now, in sticking with my theme of post-refractive eyes, I'm going to switch gears again and move into custom soft. Now, soft lenses historically have a history of being a little bit more forgiving than rigid lenses when fitting. That being said, contact lens discomfort and discomfort-related dropout remains to be a huge issue in our clinic, not just for post-refractive eyes, but for patients of all kinds in general. Some of the reasons we see contact lens dropout, ocular surface issues, but also a mismatch of ocular shape to a plastic. That means that the height of the lens may be inappropriately matched, the diameter perhaps too big or too small for an eye shape, and then of course base curve we look at as well. It's kind of an area that has been increasing in interest. In fact, the development and the improvements that we've seen in understanding comprehensive ocular shape has kind of allowed us to kind of become interested again in custom soft design related to ocular shape. And here's a perfect example, a patient again, post-refractive, that same tabletop shape. This patient was a 39-year-old female who had PRK in 2016. Prior to surgery, again, a really high myope. So -6 leaves a pretty flat, kind of dramatic shape from that curve that once was. And because of this, the patient was unable to wear commercially available or conventional lenses. We've tried an 8.4, 8.6, and a 9.0 due to instability of vision. And I teach you a little bit about why that happens, but we've all had these patients in our clinic after they've had refractive surgery complaining with soft lenses, a vision that fluctuates and just isn't comfortable the way that it was. And these are in patients that regress a little bit. So this patient was around like a 175 power that had kind of regressed since 2016 after PRK. Now, patients could be put into hard lenses, and many are. A lot of our post-refractive end up in a scleral again, or into a corneal GP, which will really neutralize any irregular optic and kind of cushion that shape. However, some patients just don't want to be in a hard lens. They want the ease, number one, of no correction. That's why they had refractive surgery. But a soft lens for a lot of them is really desirable because that's what they had in the past. And so this patient really adamant that she did not want hard lenses, did not want to wear glasses. And so was a great patient to trial a new sort of design idea that optimizes ocular shape using scanning technology and kind of matching kind of a novel dual base curve design. So here's a schematic showing kind of the challenge that I mentioned, in that our patient wearing an 8.5 lens, which was a very steep fit relative to the central eye shape, would have fluctuation of vision. Whereas a 9.0, where that base curve is very flat relative to the peripheral curve, so fits the center, but didn't really fit the side, that causes a lot of movement that fluctuates vision as well. Now, in the case of this study that we did, that's now translating into designs that will be commercially available on the market, we used comprehensive ocular surface topography, including corneal shape and the scleral profilometry, or the scleral shape, to predict sagittal height of the eye at a 15 millimeter cord. Now, again, this is very useful to appropriately hit the right numbers when we're designing a custom soft lens. We can use profilometry as well to evaluate the height of an eye to also choose lenses that are commercially available. There's a study called the Pacific SAG study out there that actually was a really cool look at heights of all of the commercially available or conventional lenses on the market. And sometimes what I find in the clinic is if I'm running into a roadblock where a patient is just not happy with a lens fit, uncomfortable, can't really figure out why, sometimes it can be linked back to an inappropriate height of a lens to an eye that just isn't that height. And so using SAG data does help normal shape eyes. And in this case, we used it to help to design a custom soft lens for a patient. The design is a novel dual base curve and through Art Optical that combined the 8.5 and the 9.0 base curves with a central kind of 8 mm zone, which about matches the typical ablation zone for refractive surgery. So centrally being that flatter 9.0 that transitions into a steeper base curve to accommodate the tabletop shape. Now, the big difference that we noticed in this lens, so if you kind of take a look at the figure on the bottom right, again in the 8.5, so steeper lens had flexion with blink was the biggest problem. Lens is not very well centered, so slight decentration, but the biggest problem patients had with the steep design, flexure, poor vision. Moving to the right in the figure, 9L, biggest problem patient had was excessive decentration. You can see this lens on the eye just wants to kind of float away, way too flat, but that's the only base curve that worked for stable central vision, aside from when the lens is moving all over the place. Now with the dual design, a 9085, in the image on the right, you can see it's a much better match for shape, and the lens is more stable, better centered, more successful. So it's kind of a cool new customized soft lens utilizing the digital data to kind of hit the sagittal height, and then also using dual base curves in the center to more optimally fit the patient. So this is again, cool, successful, neat, fun case to work on. And we'll see a lot more of this coming out the pipeline when it comes to, again, utilizing comprehensive shape to really optimize what we decide to do for our patients. Here's that lens on eye, looking pretty good, if I do say so myself. Now, second patient, just another example of a corneal GP empirical design, high power, nothing really too crazy with this guy other than, well, I mean, actually, you know what? It is crazy. -14 is pretty crazy. And he does have SIL, so he, high pathologic myopia, but as far as the ocular shape, the only thing that was a little bit atypical for him was a steep inferior cornea. And so again, had some difficulty in the past wearing corneal GPs due to decentration. And so needed new lenses, decided to try kind of cut the line rather than refitting him in a new design based off of putting lenses on and off in the clinic, mapped him out. So his cornea is a lot more regular. He has astigmatism, but nothing, no prior refractive surgery. Inferior cornea a little bit steep, as I mentioned before. But we design lenses purely empirically, and this is what it looked like. Pretty nice. I mean, pretty sweet. He had good success with the comfort, and then our fiddling around became more about how do we optimize his multifocal optic. So he felt like his lens fit was great right off the bat. So just some really great examples of just how we can now embark into the new generation of fitting lenses, kind of like I said, similar to corneal GPs, analogous to OrthoK, empirical design based on shape. And we've done this for, a very long time with other topographers, and now the ESP we're using it with the ESP as well. So things have been really fun in the clinic using profilometry for our corneal GP fitting. Yeah, and just one last video to leave you with about this patient. Looks nice, doesn't it? Beautiful fit on the eye.
Okay, that was terrific. That's like from Dr. Wolf and Dr. Morrison, like a master class. Really terrific program. Thank you very much. So now we go into some Q&A. There might be some questions in the chat. Let's see. Looks like Elena may have answered a few. If you do, I think we've got Dr. Wolf here and Dr. Morrison. The QR code there is a way if somebody does want a virtual demonstration of the device, they can use that QR code to send us some information. So we do have a question there. Are there plans to load GPs into the updates?
I can answer that. So yes, absolutely. And there are a couple of designs that we're currently beta testing that are going really well. So it'll be very similar to other lens modalities in that there will be algorithms that'll end up readily available for certain GP designs.
Excellent. And then the same question for custom softs and hybrids. I would say the answer is yes. Just as a representative of the company, we're always adding lenses, and we're really trying to push into these areas. And we do, for those that might not have heard me before, we do 2 formal updates a year on the software, and we do those updates for numerous reasons. One is to add some features directly to the software. Another is that there are some lens designs that when we add them, we do need to add, we do need to do a formal upgrade. Otherwise, some of the changes that we do are in the cloud. And so, for example, if Bausch & Lomb has a little tweak to their algorithm for a particular lens and we think it's going to make a better fit, we can do that in the cloud, and you don't notice it until you get a lens and the patient's really happy. So one thing I guess I would ask both um, Sheila and Aaron, a question I would have that I do get from time to time when I'm doing virtual demonstrations is, are there some basic things or some basic points that you would share about the difference between the eaglet and a standard topographer in terms of when you're using them? Sheila, do you want to start with that?
Yes, I can start. So probably one of the things that I like to look at is what kind of surface area I'm going to be needing for a particular lens design. So it's, of course, when we're looking at building a lens that extends beyond that central section of the cornea, there are advantages. I use it a lot for determining a modality of scleral, and that with the ESP is something that we can do a little bit more easily. There are a lot of ways that other topographers extrapolate data. The nice thing about profilometry is it's really a live image based on elevation. And so it's very accurate beyond that corneal shape way out into the sclera. And so just for kind of picking lens modalities, and if I know that I'm going to need something that's a little bit broader, I'll always reach for a profilometer.
Okay. Aaron, do you have a comment on that?
Yeah, I mean, I agree. I mean, it's there's a few things here. So like with traditional topography, there are certain things that matter, like even like the direction the eye is in, like how if it's fixated directly on the target, slightly nasally fixated, things like that. It'll change your map a little bit. The nice thing with Eaglet is you've got these 2 projectors that are coming from the side, so you're going to get really reliable, accurate data, even if the fixation is not exactly always exactly on. And some of these patients just have really poor vision, as I think we all know. So they were doing their best to focus on the target, but sometimes they're just seeing like just a massive red blob or something in their view. So it's a little bit more forgiving, I guess, in that way. Obviously you're going to get a wider scan. That's a really huge component. What I found also is in particularly irregular eyes, like corneal grafts, maybe even like more extreme keratoconus, you're going to really struggle, I think, on some other devices, whether it's a different type of projection device, or if it's like a scanning kind of tomography more based device. They'd struggle a little bit more with particularly irregular eyes. It's almost like the software doesn't quite know what to do with it if there's too much of a jump in elevation, or the tear film just breaks up too much on that really high elevated kind of spot. The Eaglet, it doesn't really matter because there's tear film, no matter the elevation change, how extreme or mild, it makes no difference. There's going to be some amount of tears over top of that. And so the device can basically project those grids onto that tear film, and those really more complicated cases it just kind of excels in.
Okay, excellent.
Ted, I'm going to throw in one last thing that I thought of is another differentiation for which topographer to choose is what I'm planning to do with a manufacturer lens design. because there are different compatibilities with topographers to be able to build lenses, especially if we're looking at making an empirically designed lens, or, labs generally play pretty nice with most topographers, but there are some that are superior with one topographer or the other. So as we all know, the ESP is very compatible and friendly with, very good with teamwork with other variety of other companies. And so that kind of sometimes makes the decision for me. If I know I'm going to work with, say, I want a Smart 360, for example, like our HOA case last night, I'm going to automatically just go straight to using an ESP. It's going to be one of those things that's a no-brainer because that's the best choice for that lab.
Okay. Yeah, that's a good point. We're lab neutral and we've got the most labs and the most lenses. Okay, well, I don't see any other questions here. I just want to thank Dr. Wolf, Dr. Morrison for being with us tonight and sharing the webcast. It was really terrific. I learned something every time I listen. And so with that, I will bid everybody good night and have a great weekend.